Can we see a röntgenogram?
Yes, of a child.
So this is a child, I think about age 9 at this point, and at this time, this child had a severe mycoplasma infection, but as you can see here, it didn't seem to be involving his lungs. Lungs look pretty clear, but he had severe skin lesions. He was thought to have Stevens-Johnson syndrome. He was sloughing, large quantities of skin, and they cultured mycoplasma from his skin and from his blood, but he never really had that much in the way of lung infection. I mean, maybe there's some stuff down here, but it's pretty iffy. But at any rate, he recovered from this acute mycoplasma infection, and a few months later complained of shortness of breath. So let me bring you up to date with a more current chest radiograph. I hope I can advance here. I have to go back here. So here's what his chest radiograph looks currently, and now you can see that he's got hyperinflation, and he's got this basal rarefaction of vessels down here. He's got a nice flat diaphragm here on lateral views, so it looks as if he's got obstructive lung disease. You'd think, just seeing this might be alpha-1 antitrypsin deficiency, but on CT, this is actually mosaic attenuation, and I'll just change the contrast here to bring out the mosaic attenuation. They didn't do expiratory views, so I can't document air trapping, but it certainly looks like that possibility. His pulmonary function is continuing to decline. He has severe obstruction. He also has bronchial thickening here and very mild bronchiectasis, not a huge amount of dilation, but a lot of bronchial thickening. So he's got small and large airways disease. He's had a few episodes of colonization with staph, I think MSSA. And then he probably has some more recent infection or aspiration down here. He's got this subpleural bleb. Down here is kind of strange gas collection. So putting it all together, this is likely a case of constrictive bronchiolitis that developed post-infection. So mycoplasma is one of the organisms, when it causes pneumonia, that's associated with Swyer-James syndrome, constrictive bronchiolitis, post-infectious. It's one of the more common ones. So adenovirus and mycoplasma are sort of top of the list. So it's not clear whether in his case, though, he had actual mycoplasma infection in the lung or whether he had an immune response to his mycobacterial infection. And this is kind of a immune-mediated constrictive bronchiolitis with eventual bronchiectasis that he developed here. Anyway, it's tied to his mycoplasma infection in terms of timing and persistence. He's ultimately going to get a lung transplant. It's hard to believe, but this fellow was actually recruited to play competitive soccer, Division III soccer, by his college. And it's only been in the last year or so, I think he's now a sophomore or junior, that he's had to lay off of intense exercise. But just shows you the tremendous reserves that young people have. I think it's disgusting. So this is constrictive bronchiolitis. Presumably, it's not been biopsied, but ultimately he will have lung transplant, and then we'll know for sure. And this could be Swyer-James if there was mycoplasma infection in the lung, but otherwise it may be part of the immune response. He had sky-high IgM levels to mycoplasma at the time of his infection.
Wow.
So, and then I don't have a good explanation for this little gas collection. It almost looks as if it's in the leaves of the pleura or something. It's by its shape. I don't think it's a loculated pneumothorax. It's too discrete for that, but bizarre gas collection down there. Okay. Now my other case this is also a child, I think 11 or 13 years old, something like this, from Kuwait. And at this point, he had this chest radiograph because he had neurologic findings, and he was shown to have a dural venous thrombosis. So he also had some superficial vein inflammation on his arms, I think. I'm trying to get his history at this point. Right now, it's all secondhand. So his chest radiograph is fairly normal. And then 3 months later, this was that was September of 2016. Here is December, and he's now got this big lesion in his lung base down here. And this was CT'd. And There's a CT scan showing that this thing slowly fills, or at least partially fills, with contrast from the injection here. And this thing seems to connect with a pulmonary artery at this point. So this is considered to be a pulmonary artery pseudoaneurysm. He has pleural effusion on the other side. So he had an angiographic procedure, and they placed a balloon, and they basically blocked off the blood supply to this big thing. And here's a follow-up CT now. I think about a month after this procedure, you can see that the big lesion has shrunk down and cavitated at this point. And here's the embolic device here in that pulmonary artery that was feeding this. So this is a pulmonary artery pseudoaneurysm. And the rheumatologists have put this together as Behçet syndrome. Evidently, superficial venous thrombosis, and that can include dural venous thrombosis, is a prominent finding in this condition. And he's from the right part of the world. He's from the Middle East. So Behçet syndrome, I didn't know it was a disease of young people like this, but and I'm still learning about this case. I haven't really looked it up yet, and I don't have all of the history in command. But I thought you guys would want to see one of the bad things you can have, pseudoaneurysm, probably because of like a necrotic attack on the inferior pulmonary artery, resulting in this big lesion that filled with contrast.
Wow. Wow, really?
So yeah, David, I've only seen one case of Behçet disease with it was a guy who had sort of pulmonary artery aneurysms with in situ thrombus.
Right.
And
I think the thrombosis is a big part of this. Yeah, go ahead.
Right, and they get and the problem is the vascular involvement seems to only affect males, and it's associated with a bad prognosis. He just seems to have that isolated one. Mine looks like almost like a chronic PE case, except it's just lots of in situ thrombus along the walls, and he had pulmonary hypertension, and he had the full ulcers and all the other stuff that goes along with it. But it is somewhat variable in its presentation.
Yeah,
but I like that. That's a great example.
So I talked to some of our Turkish docs around here. I tried to get the right pronunciation, and the C in Turkish that has a little cedilla under it, that little accent mark under, is pronounced like CH, as in, chip, as in potato chip. So it should be Behçet or Behçet syndrome. That's how the Turks say it. So we're trying to be faithful to that. Okay, those are
great
cases. Yeah.
Hey, Brett, do you have cases this week?
Yes, I have a couple.
Excellent. All right, I'll turn it over to you.
Okay, let me bring this up. Okay, let me figure out which. Okay, okay. So this just have a couple. This first one is just kind of a quick one. Can you see the screen?
Yes. Good.
Okay. All right. So this is a young patient in her 30s who, we're scrolling down here, and you can see that she already has. We can already see that she has symmetric axillary lymph node enlargement. Scrolling on down, you can see that her heart is a little bit enlarged. She has some pericardial fluid there. She has some pleural effusions, trace pleural effusions bilaterally. And then if you look at her lungs on the coronal view, let's see, just really, really low lung volumes here. And you have at the lung bases really no fibrosis, but just some crowding and some atelectasis, in the lower lobes and posterior upper lobes. And this is a patient who has lupus. And so, I know that another case was presented not too long ago at this conference. And so this she's been having some chronic dyspnea. So this could certainly be shrinking lung syndrome in lupus. So I just wanted to show it as a good case of multiple findings that you kind of expect to see in lupus, including the axillary lymph node enlargement, pericardial pleural effusions, and potentially shrinking lung syndrome. So
Brent, ask you about right there, looking at the diaphragmatic crura, because Dave talked about him before.
Travis's case had thinning of the cruce on both sides compared to an earlier CT, and this cruce looks nice and robust. So I was hoping as you were going to have another case that showed the atrophy or the loss of good muscle thickness of the diaphragm. But this case is a huge disappointment to me. I think you should not. You
should not what?
You can start this case.
Oh. But anyway, that was just a quick case to think about. And then here's another case.
So Brent, was there a change in lung volume on this person from earlier exams? Was this an acute decline? Because there was a dramatic decrement in, I think, Travis's case, or really a big loss of volume compared to before.
This, unfortunately, this is the only one that we have. This is kind of a newer patient to us, so we don't have the priors on this. But of course, I mean, it's possible that this is not, I'm billing this as possible shrinking lung syndrome, but it's possible that some of this is due to obesity, but we did have a couple of radiographs from the past where I don't recall how much in the past, but they all showed very low lung volumes and was never quite taking, the lung volumes were never quite normal, so there were this decrease. So, so I'm billing that as potential. Okay, so this one is another more interesting case here. This is a patient who came in for head trauma from, let me see if I'm showing the right screen. Let's see. I believe so. So came in for head trauma and had a lot of procedures and lines and tubes placed elsewhere before coming in. So you can see here a few lines and tubes, and here I'll call your attention to this Dopphoff that's coming from the neck and going down, and looks like it's going to the stomach. So I didn't, I think I saw this. I didn't really think much about this radiograph other than just the other findings going on. But let me show you a CT that was done. Let's see, let me pull the right CT here. Let me see if I can show the screen. Okay. And here's a, whoops, that is not the right one. I'll pull up the right one. Okay, here's the right one. So this is done the same day, and okay. So here's the CT. So you can see that as I scroll down, the enteric tube that we have right there is going down, and let me keep scrolling, going down, and just looks a little funny. And look at the mediastinum. Mediastinum has some extra contents, and looks like edema and/or blood in the mediastinum. And let's go up a little bit here and see up here that the enteric tube makes a little bit of a funny lateral course up there, but seems to go down, and then let me scroll down to the abdomen. And you could think, well, this is just going to the stomach, but there's something very strange going on in the mediastinum. So something very suspicious here going on. Let me show you a CT that was done. This is
before you change, Brent, lower down near the GE junction, where is the tube in relation to the lumen?
That's a good point. So down here, the tube is, if this is the esophagus, then this tube looks like it may not be in the esophagus. So that was the pickup here. You can see up here it's much harder to tell because we have this hematoma, and who knows where the esophagus is. But down here, as Howard just pointed out, it looks like this could be extra luminal down there. So very suspicious. And let me show you a CT that was done. This is from a neck CT. I want to make sure I'm showing the right screen. Okay, and here's the, let me start from up here so you can see some of the head trauma up there, but let's go down to the tube. So the tube is here. So it's very lateral. It's kind of going, looks like it's perforating through, you know, maybe near the vallecula here, and then look at that. It goes down the mediastinum, but it's actually outside the esophagus. And here you can see more extraesophageal air and fluid and hematoma. And this is actually perforating the upper, in effect, the oropharynx up here at some point. And then it went down the mediastinum and it followed the esophagus. But as Howard pointed out, it was actually, it's actually extra esophageal down here. So it went all the way to the peritoneum, but it's outside the esophagus. So this had caused a large hematoma within the esophagus and in the mediastinum as well. And let me show you the follow-up. This was actually confirmed. Perforation up there in the neck was confirmed by the ENT service. And let me show you the follow-up. We still have a hematoma, larger hematoma now in the mediastinum. You can see there. So again, not performed here, but the sequela we could see from this extraesophageal tube placement. So,
Do you think they placed this over a wire that gave it enough stiffness to do the perforation?
I think so. I mean, presumably, because that would take a lot of force, and I think that it must have had a sharp, stiff tip to that for that to occur. But you know, certainly the only sign on the radiograph would have been up here. You know, where I feel like a lot of these are so rotated, like, you know, that it's hard to make that call. But you know, but don't see much in the way of extraesophageal air here in the mediastinum. But any other subtle signs that anybody would have said on the radiograph, you know, up here and
No.
But
discouraging case because you can't really pick it up.
You know, up in the left neck, now that we know where it's going, one could say it's a little bit too left of the spine compared to, now that we know what to look for, compared to the tracheal tube, which is next to it, I suppose. But, oh gosh, I don't know. Yeah.
I thought it was very difficult.
The right pleural effusion or the fluid is perhaps unrelated to it, or?
Well, she'd had trauma, so presume that was part maybe near, yeah, I think part of another process, but because I don't think that, let's see, let me just remind myself about whether, well, there's a little bit of thickening there, you know, so, but this had happened, you know, a couple days prior. Well, this is actually the post, so this had happened a couple of days prior to presentation here, so, but I just thought that was a dramatic case.
Yeah. You know, putting tubes in patients who are on ventilators and can't vocalize pain and so on, it's always a scary situation.
So, but that's all I had this week.
All right. Well, thank you. That was impressive. Okay. Well, that's it for this week. Travis should be back.
All right.
And thank you, everybody.
Thanks, everyone. Same time next week.
Yeah.
Thanks.
Bye, everyone.